Thank you for the invitation to come. These are great. What?
The way you spell pediatric.
Oh, yeah. I told Bill I'm giving a talk and they've misspelled the word pediatric. So why preemptive genotyping now? A couple of things. The turnaround time between the decision to prescribe a drug and getting the genetic test result is generally too long, as we've talked about already this morning. So having genotypes already done would be a definite advantage for prescribing. The cost of genotyping has come way down, and it costs about the same in the US to get a clinically certified result for a single gene as it costs to get a clinically certified test for over 200 genes. So that makes running a panel of pharmacogenetically actionable genes for a small amount of money feasible. And people are at reasonably high risk to receive at least one high-risk, one pharmacogenetically high-risk drug for at least one of these actionable loci, especially over a lifetime. So the chance that genotype data will be used is high. And to give some examples of this, a few years ago, admittedly at St. Jude, we have a high-risk population of children with catastrophic diseases, but we looked to see, at that time, 33 pharmacogenetically high-risk actionable drugs, how many patients had received these that were subject to the first 11 CPIC actionable genes, and we found that about 48% of our patients had an order for at least one of those drugs in just a one-year period, and this is remarkably similar to what Dr. Roden's group published at Vanderbilt, which is presumably a much different population than children with cancer, where 54% of their population at an academic medical center was exposed to one of their 56 pharmacogenetically high-risk drugs over a one-year period. And of course, as time goes on, you're more likely to be exposed to those high-risk drugs. So who knows where the true answer lies? There's starting to be more and more data published on this, and probably you, and I'm hoping Yessi can provide us some more information. So this was a study in the US. It's difficult in the US to figure out which drugs are actually used because of our fractiousness. So they chose 61 drugs for which pharmacogenetic guidelines were available using CPIC level A and the Dutch working group recommendations. They chose 9 genes. They excluded some genes that are pretty important that are listed here. It was a 4-year period. It was 73 million patient records using both private and public insurance, which in the US is Medicaid and Medicare. The highest frequency of high-risk drugs was for patients who were older, which is no surprise. 50% of these patients had received at least one high-risk pharmacogenetic drug, and up to a third had received more than one pharmacogenetically high-risk drug. And what they did, which we're often asked about, is, well, what's the co-occurrence? Not just the use of the high-risk drugs, but the concurrence with the high-risk genotype. I wanted to remind people, this is from the CPIC site, these CPIC level A or B, and they excluded all CPIC level B drugs in this study, are actionable to some extent, and we can talk more about how we come to those levels during the discussion. This list we try to keep up to date. You're welcome to give us recommendations if we've got it wrong. There's currently about 120 actionable drugs on the CPIC level AB gene list. So going back to this paper where they reviewed millions of prescribing records, each column is an age group and an insurance group. So for children, 11.2% of children less than 13 years of age received at least one high-risk pharmacogenomic drug, and that went up to a maximum of about 55% of older Medicaid patients who received at least one high-risk drug. And of course, the percentages go down as the number of high-risk drugs goes up. And we've already seen this slide this morning. We had estimated, and anybody can do this, that basically about 99% of people have at least one high-risk genotype, even just looking at the first 12 CPIC actionable genes. And that's true whether you're European background or African ancestry background, but of course it differs for some genes like 3A5. It's quite different depending on the ethnicity of the person. So putting this together, the presence of the high-risk actionable genes with the prescribing of the high-risk actionable pharmacogenetic drugs, they came up with a percentage of those two things occurring together of less than 1% in children under 13 years of age, and about 5%, 4 to 5% of older Medicaid patients who tend to be sicker. And I've heard rumors that other groups have come up with sort of similar frequencies as this. So this is surely an underestimate. They left off many of our very actionable and most important medications and genes, so I'm sure that the number is higher than 5% of the population likely to have a high-risk genotype and be prescribed a high-risk drug in their lifetime. But it's not going to be everybody. So we sort of have to decide how high does that percentage have to be in order to think that it's worthwhile to take this action of doing preemptive genotyping. And of course that depends on how expensive the genotyping is too. We mentioned pharmacogenetic guided prescribing is not widespread, and in the US, 7% of hospitals were stated to offer pharmacogenetic testing a few years ago in a national survey, and that was up from 2.7% a couple of years earlier. So it's still true that genomics is not used much to inform prescribing. There was even a study of a large academic medical center, the University of Washington, where they had over 3 million hospital and clinic visits involving several 100,000 patients, and they just looked to see 4 drugs for which the FDA-approved drug label either recommends or requires genetic testing. Was genetic testing actually done for those patients? Only 1.5% of the time. So when somebody said a Vacavir changed because the label changed, changing the label is not enough. Something else has to happen too. So knowing all this, several years ago at St. Jude, we decided that we could overcome or ignore many of these barriers to preemptive genotyping. I'm lucky to work at a place where we cover all of our patient care costs. Patients don't have to pay for any of their own care. We provide all medications from my department for all of our kids. They all have very serious diseases. They will die of their disease if we don't treat them adequately. And their drugs are really dangerous, so they will die of drug adverse effects if we don't use them the right way. We have a team-based approach to patient care, and our clinicians are used to using evidence-based prescribing, and we have an integrated, comprehensive electronic healthcare record, which for us is provided by Cerner. And we've been used to building customized decision support for over 15 years because the decision support that comes off the shelf with these software packages don't exactly handle children with cancer. So we opened a study, PGen for Kids, in 2011, and the goal was to implement preemptive pharmacogenetic testing for all St. Jude patients. The idea was we could move a gene into the medical record if we had built the CDS that supported at least one drug, and that once a gene moved into the EHR for one patient, it moved into the EHR for all the previous patients as well as the future patients. And we would provide all the information freely to patients and to anyone who wants it. Why are we doing this versus via a research protocol instead of just best clinical practice? Well, of course, I do hope that someday this can just be best clinical practice, and maybe we're already at that day, but here was our reasoning. We use an array to test, as I said, for 230 genes. It used to be DMET, now it's PharmacoScan from AFI, from a CLIA-certified lab. The process in order to move those results from the array into the EHR is very complicated, but of course we could have done that without a protocol. But we did feel we had to get informed consent for the fact that we were going to withhold most of the results. So the vast majority of the genes on that array never make it into the EHR. They stay in secure databases in our department. And we also had to have a consent process for handling incidental findings, any pharmacogenetically interrogated genes that would have implications for disease risk for these children. And we knew that we have to repeat consent when a child turns 18 years of age, or if the patient doesn't reconsent, they can't keep getting results. We consulted with a family advisory council at St. Jude before opening this study, and you can still see this video on the web, I think. It was really helpful to get input from parents. They had a lot of ideas that we incorporated into the protocol, and we continue to engage our parent advisory council, giving them reports on a regular basis. And as I think somebody said earlier, the patients ranged from, why are you telling me about this? I had assumed that you were already using genetics to handle my prescribing. Don't bother me, to I want to decide every time a result goes into my medical record. I want you to consult me for my child's result. No, that doesn't work. Then we have to tell that parent, well, then you don't get to enroll on the study. But that's how strongly people felt. There are a few special considerations in children. Of course, kids clear drugs better than adults do, so that makes every other thing that is important in adults more ignorable in children. They're better protoplasm and they handle drugs better. Some incidental findings are more likely to be discovered or actionable in children than adults, and we have found 2 cases of Klinefelters. So that's about 1 in 600 males. You are going to find it. If you have an X-linked gene, and G6PD is one of the best known pharmacogenes there is, it's really easy to tell when a self-declared boy has 2 X chromosomes. So you definitely need consent for that. Because informed consent was needed for this, the parents have to consent on behalf of the patients. And our IRB said parents are not allowed to refuse incidental findings on behalf of their child. So we do say if we find a genetic risk factor for disease, we have to tell you about it, and we have to tell your doctor about it if it's actionable before the child is 18 years of age. If you can't live with that, then don't participate in the study. And then, as I said, we have to reconsent at 18 years of age. Also, of course, there's, because we're testing kids when they're young, these results are going to be important for the rest of their lives. So it would be nice if we had a way of making these results be lifelong results. I already mentioned the kinds of incidental findings we think are necessary to report to children is a very high odds ratio association with disease risk, not likely to be discovered via other means. So like a genetic factor that increases your risk of type 2 diabetes by 2 or 3-fold isn't as important as being obese, and so that probably doesn't count. And it has to be actionable before the child is 18 years of age. Prior to 18, we have to tell them. After 18, the child can refuse that information on their own behalf, but a parent can't refuse that information on their behalf. So a theoretical risk we could have found is, let's say if we have a pharmacogene that predisposes to teenage onset of colon cancer, we would have to report that because you would do something about it. That hasn't happened, but as I said, the Klinefelters has. I really like this. I found it on the web. I think it's somebody making a little satirical website that the American Academy of Pediatrics admits that children really are little adults. So, you know, children are different than adults. I've worked in pediatrics for 35 years, but I think sometimes we play up their differences too much. In a lot of ways, they don't need to be treated differently. For one thing, they become adults really fast. And in all pediatric settings, including ours, treat children that are over 18 years of age. After puberty, they're really biologically like adults. You have to get informed assent if the child is over a certain age. And of course, germline genomic variants do not vary with age. That's one of the beautiful things about germline genome. If you have the CYP2D6 gene deleted in both copies of your genome, you're not going to be able to metabolize 2D6 drugs whether you're 6 months or 60 years of age. So we're approaching implementation two ways at St. Jude. One is through CPIC, which I co-lead with Terry Klein at Stanford. And part of the reason that we formed CPIC, or that I wanted to form CPIC, because we wanted to do this pharmacogenomic implementation preemptively at St. Jude for every patient. And I don't have enough expertise to write all those gene-drug pair clinical guidelines. So we've tapped international expertise, including fantastic people like Munir, to help lead our authorship groups and write these gene-drug guidelines. And the reason we did it was that in 2009, we did a survey of people who cared about pharmacogenetics, and we asked them what their top 3 challenges to implementing were. 95% of people said the process required to translate genetic information into clinical actions was their biggest barrier. And the next was how to interpret the genotype tests, and they wanted to know which gene-drug pairs to implement first. And that's important because we're barraged and bombarded with for-profit laboratory companies that are selling genetic tests to clinicians and direct to consumers, many of which do not have adequate evidence, and they're creating a bad reputation for genetic testing. And we want to be there to say, we believe in genetic testing, but not all genetic testing is right. So this is from the CPIC website, and a primary assumption of CPIC that has been critical is that we only are writing these guidelines to help clinicians decide how to use available genetic tests. We pretend that we are 10 years in the future and everybody's genome is done. The challenge is not whether to order a test or whether it's patient point of care or preemptive or whatever. The test is already there. The challenge is what is so important that you would be wrong not to act on it in the clinic if you knew about it. And so that helps us get out of all these cost effectiveness decisions. We're saying, you've already got the genetics, how do you use it? So we've done, I don't know, this is out of date, but I think we've got 24 guidelines starting in 2011. We have to update them as the information needs to be updated. A huge one that just came out in the last week was CYP2D6 and tamoxifen, which has taken many, many years to get a guideline for, even though we've known about that gene-drug relationship for a really long time. So as I mentioned, our local protocol at St. Jude is trying to preemptively do this genetic testing, and our goal is to have all CPIC gene-drug pairs eventually done in our patients. Exclusion criteria are patients who've received a prior allo or liver transplant. We enroll the patient, get a blood sample, use an array to genotype for 230 genes, put all the results in a research database, and selectively put those genetic tests into the EHR one gene at a time as we develop clinical decision support for at least one drug, and then we provide that information to patients and to clinicians. So we're using DMET's PharmacoScan. As I said, we have a lot of quality control prior to upload of these genetic tests into the EHR. A huge challenge is concordance of not a huge challenge, but something you have to pay attention to is concordance of self-declared sex with genetics. A huge challenge is what to do about concordance with new genotyping results compared to old genotyping results. And we haven't completely solved that problem. We have an oversight committee. Actually, Dr. Roden is on it, as well as many members of the clinical staff at St. Jude, and they have to approve each new gene-drug pair that goes into our EHR, and that reports to the medical executive committee. We've done 9 genes starting in 2011, going up to the last few months. We're continuing to work on a couple of genes and adding new drugs to old genes all of the time. The most recent was CYP2C9 and celecoxib. So we have 22 drugs that have CDS built around these 9 genes. And this just illustrates the percentage of patients that have a potentially high-risk diplotype for each of those 9 genes. So for some of them, you can see it's very high. For some of them, it's very low. It's still a disaster if you give 5FU to somebody who has a DPYD variant that's inactivating. So we want that CDS there, even though it's not common. We've enrolled over 4,000 patients. 94% have consented. almost 99.5% have reconsented at the age of majority, and 2 incidental findings out of all of these. They involve all different therapeutic areas at St. Jude, including HIV and non-malignant hematology. So our big challenges are, how do we get from the diplotype to the interruptive CDS for prescribing? And I don't have time to go through this in very much detail, but I'll walk you through a few examples. You basically start with 2 SNPs at a certain locus, and you have to figure out how to turn that into prescribing information for the prescriber based on this genotype predicted to be an intermediate metabolizer. Consider starting 6-MP doses at 30 to 70%, blah, blah, blah. Our CPIC guidelines try to provide the information that clinicians need to go from genotype to that active CDS, and these pages and tables are updated as necessary for each applicable gene-drug pair. A big part of what they do is translate the genotypes into alleles and assign functions to the alleles. And those are through these tables that are highly curated. Every row is a variant. This is for one gene. Every column, 5 different ways of annotating the location, the genomic location of that variant. And our authors have to agree to the assignment of function to each of those alleles for each of the CPIC actionable genes. We have to translate the alleles into diplotypes. People have 2 copies of the genes. You've got to figure out how to phase them. So many times clinical labs don't want to bother to do that, but we have to make them actionable, because usually being homozygous for a variant of a gene has a very different prescribing recommendation than just having 1 variant copy of the gene. And there's lots of diplotypes. This is CYP2D6 in the first 4,000 patients, 207 different diplotypes. And that has to be translated into 4 or 5, tell me it's not 6 or 7 phenotypes. TPMT is much simpler, a very well-behaved gene. They should all be like this. AFI software does a good job of converting variants into alleles and assigning haplotypes. But there's other ways that can be done too. We have to translate the diplotypes into phenotypes, and that's provided by CPIC guidelines. And at St. Jude, we translate that into a genetic test result on the pharmacogenetics tab, which we have created in our EHR. It's not date dependent. Genetics is a lifelong test, so you do not want clinicians having to search by date. And if it's abnormal, it's highlighted in red. If you click on the consult for the CYP2C19 gene, there's an automated system that assigns default language for the interpretation of the diplotype that does have to be signed by one of our pharmacists, and they can customize this based on drug use and other phenotypes. We have a database that helps create these templated interpretations for us. And then, of course, we have to translate phenotypes into actionability. And we think about our interruptive CDS alerts in 2 ways. The pre-test situation, you have to check if the patient has had the genetic test done or not. So if we don't start agreeing on how the nomenclature for genetic tests, we are going to be in big trouble. You can't check if a test has been done if you don't even know how the test is referenced in the EHR. And then in the post-test situation, if the patient is prescribed the drug and they already have a high-risk result, you have to be able to find it to fire at them the right alert. So this is what a pre-test alert looks like in our system based on the absence of a test result. A CYP2D6 genotype is recommended before prescribing codeine. Does not appear to have been ordered, blah, blah, blah. Has a checkbox for them to order it right then if they want to. The post-test alert, the patient already has a high-risk genotype, and so they've prescribed codeine, and they're going to get a warning about please don't do that, and here's some alternatives, and you can call the pharmacist if you want more alternatives. Of course, if we've been talking about genetics is not everything, that's just what the title of this meeting is. But we have to have alerts that also sometimes take into account the route of administration or age, as we do for, I think this is voriconazole. And also, sometimes we have to use 2 gene test results to decide how to prescribe. And that's very complicated logic, but it's starting to be more common. I also make the point that we have not let perfect be the enemy of the good. So we are putting genetic test results into the EHR as long as one drug's supported by that. So CYP2C19 affects a lot of drugs, and when we put it in, we only built the CDS for voriconazole and tricyclics. And I had a kid about 6 months ago, they consulted me for another reason, a little 11-year-old boy towards the end of his leukemia therapy. He was having GI trouble, so they had him on omeprazole. He was having hematemesis, ended up having to be admitted to the hospital because they had progressed into esophageal varices. And turns out that he was a CYP2C19 ultra-rapid metabolizer who there was no alert telling the prescriber to give a higher dose of omeprazole or a different PPI because we hadn't built it yet. So I couldn't really yell at the pharmacist too loud or at myself. But luckily we used the Dutch guidelines. We've already got something at least in draft form for this, and we're able to change the dose and get the bleeding to stop. So we've been doing this for 7 years, and we've only done 9 genes. This is just a shortened list of all of the steps that have to take place for every gene to move into the EHR, which include all these committees, the education, working with our laboratory people, competencies for the pharmacists. So it's been a slow process. That's because every drug requires this active creation of this CDS, which hopefully people like NHS will create this CDS, and then we won't all have to be reinventing the wheel ourselves. We have a bunch of websites and materials we have to update, get committee approval, etc. So it's been a slow process. We're also using genetic testing as a quality index measure at St. Jude. Our goal is to have 100% of patients with leukemia have their TPMT genotype known before their first dose of thiopurine, but we don't always make it. And you would be surprised at the ways that we screw up on missing TPMT genotypes. So I'm going to stop there. Hopefully we'll have time in the discussion to go ask questions. I acknowledge the team at CPIC and my colleagues at St. Jude. Thank you.